I just had a few technical difficulties. We're going to go ahead and just kind of go through a few of the housekeeping things. My name is Monique Dever. I'm with Patagonia Health. I'm the marketing executive. We have on the right-hand side of your monitor, you'll see the dialog box where you can shrink and expand the questions and audio features just by hitting that red arrow. At the end of each of his segments, the presenter's segments, we're going to have a Q&A. So if you have questions at any time during the presentation, go ahead and submit them in that questions box. And then we'll get to them at the end of each section and then at the very end of the session as we close. Okay. Our presenter today is Aaron Davis. Aaron is project manager for the Center of Public Health Initiatives, and he is specializes in project management and strategic business operations. Aaron is a Wichita State University graduate 3 times over, has undergraduate degrees in business administration and integrated marketing communications, as well as a master's in business administration. His previous work includes both government and private industry, which includes more than 5 years at the Sedgwick County Health Department. So without further ado, I'm going to go ahead and share my screen with Aaron, and he will begin his presentation. Bear with me 1 second. Sorry, change presenters.
All right, thanks, Monique. Are you looking at my slides now as I get them up?
I do see them, yep.
Okay, great. Well, thank you for that introduction, and thank you guys for joining. My name is Aaron Davis, as Monique said, and I am going to be talking with you about the last 2 years of my life and what's quickly becoming a great passion of mine. So before we get too far into this, a couple quick things I want to cover. The first being that I work for a group that is called the Community Engagement Institute at Wichita State University. We have a handful of centers here that work on various aspects of social type work throughout the state, and I, of course, as it was on the previous slide, work for the Center for Public Health Initiatives, and we work to improve the public health system in Kansas by empowering people, developing organizations, and strengthening systems. And this project that I'm going to be presenting on today is something that covered all 3 of those areas. Because our grant that we're talking about today, the project was funded by a grant from the CDC, I have to include this technical piece and just want to make sure that you all have a chance to read this and understand that everything that I express today or go over or that you see in the slides, it is not a reflection of the policies of DHHS, the CDC, the Kansas Department of Health and Environment who received this grant, or Wichita State University. So even though we're talking about or through the Patagonia platform, we do not give any specific endorsements to Patagonia or other systems. So with that, let's go ahead and get started. I want to go over the agenda. We're going to introduce you guys to Kansas and some of the aspects involved in this type of work here, go over the grant that we're talking about that led to this project, then actually talk about our EHR project, the things that we learned from it, and some guidance moving forward that we are targeting towards Kansas, but of course will apply to any health department across the country. So Kansas, capital is Topeka. We're talking about 2.9 million people roughly, and what a lot of people don't realize is Kansas is actually very large, over 81,000 square miles, and with that, Kansas is decentralized. So what we have once we combine those 2 aspects, and I'll talk about home rule, is we have 105 counties in Kansas and a total of 100 local health departments, all operating under home rule, so everyone's kind of out doing their thing. And of course we have a lot of collaboration and partnerships, but comparing it to a centralized state health department, we have a very different picture in Kansas, and I do know that there's a handful of other states that look a lot like Kansas in this regard. Most of the populations served by our local health departments are under 25,000. This is a graph from the 2013 National Profile of Local Health Departments from NACCHO. And in fact, if you were to even break this down into smaller categories, Kansas would probably still be leading that curve. So a lot of small communities here. One of the other tables really gives a good idea. I know a lot of health departments across the country that we've talked to do a lot of the same types of programs. This is a really good snapshot of what we cover in Kansas. Immunizations is of course a huge focus, along with TB, blood lead screening, WIC programs, maternal child health programs, etc. So we're going to be talking about EHRs. So the landscape of health IT in Kansas, this is kind of what it looks like. Of those 100 health departments, we have around 24, maybe a little more now since we've created this slide set, that use EHRs. 11 of them were specifically because of our pilot program. Many of our health departments use a homegrown practice management system. And of course, we have a couple out there who use free software or utilize paper, both records and for the health record and for billing purposes. Do a lot of data entry online, and of course the majority of departments, even some with EHRs, utilize all of these types of approaches. So I think we'll wait until the next section break, and then we'll do some quick questions. I want to give everyone a chance to get familiar with where this project came from and how we kind of got started. A couple of years ago, the CDC proposed a grant focused on immunizations billing, and the problem that they were focusing on was a realization that insured patients were accessing immunization services at health departments largely for free or for very nominal fees. And of course, we know that public health departments do have the ability to bill insurance, and for a lot of these costs, the counties and the health departments were eating the costs when in fact the people, the individuals, the patients, the state, whether if they were on Medicaid, for example, all of these insurance companies were basically providing or offering these services but weren't being billed for them. So what we saw there was a chance for expansion of what health departments were doing in terms of billing insurance, capturing reimbursements from individuals, and really the focus was to increase the sustainability of health departments. We know that there's money on the table, and if health departments are allowed and able and trained to access that money, we can see a greater reach of immunization efforts in our communities. So again, this was a national grant that the CDC proposed, and in 2012, the iteration that Kansas received was focused on planning. So we had a group called the Kansas Foundation for Medical Care, contracted to do some research, figure out what's going on across the state, how are health departments billing, if they're billing, and they even did a pilot project to figure out if having certified coders in health departments had a major effect, and some of that study was inconclusive. At the time the project went underway, I think there were around 2 certified coders working in all 100 health departments, and afterwards, and I think now the number is roughly around 4 or 5, so we've increased that a little bit. So KFMC made some recommendations after all of their research, and the 3 recommendations that the state of Kansas latched onto were the 3 that you see here: creating a biller-specific coding manual that could help get all health departments on the same page as it related to what codes they were using and how to bill; bringing in an outside group such as AAPC to do a coding training, and of course this was at the time when everyone was up in arms about ICD-10 and worried how they were going to go through that, so it was really great timing. And lastly, what I'll be talking about mostly today is an electronic health record pilot program. A lot of the states that received this CDC grant were focused on trying to get health departments convinced to start billing and trying to train them on how to do that. We were lucky in Kansas in that at the time of this, the majority of health departments were billing, but we had a lot of feedback that kind of showed that we weren't doing things as well as we could have. So a lot of room for growth. So it wasn't starting billing in Kansas that we needed, it was getting everyone on the same page and making sure we were doing it efficiently. So with that, we were able to take those recommendations and apply for the second iteration of this grant, which was focused on the actual implementation of these strategic plans. And at this point, the Kansas Department of Health and Environment hired our group here at the Community Engagement Institute to tackle the implementation of these projects. So I realize I just went over a lot. I was trying to make up some time from our late start because I do have a lot of things to go over as it relates to this. But Monique, do we want to take a second and see if there are questions?
We don't have any questions yet, Aaron. If there's any questions, we could pause or just continue on. If people have questions, go ahead and plug them in. Aaron, you can continue. If a question does arise, I'll let you know.
That sounds great.
You can also raise your hand if you have a long, lengthy question. We can unmute people. But I think it's best to just put it in the questions box.
All right.
Thanks, Aaron.
And feel free to interrupt me if you need to. So before we get started on this, I wanted to make sure we had kind of a similar frame of reference. I'm sure some of the people on the call are very well versed in EHRs and health information exchanges and kind of know the whole gamut of terms and understanding. But when we launched this project, it was very clear that a lot of the health departments in Kansas were not really familiar with all of these little nuances. So to go over them really quick, electronic health records and medical records, I use those terms interchangeably. They are different, but we'll be talking mostly about EHRs today. I mentioned before that we had a practice management system here in Kansas that a lot of the health departments utilize. When you talk about a practice management system, this is the piece that would be for scheduling, having the calendar, tracking some of the details of the patient in terms of demographics. And then on the next piece, you have the billing software, and we do have a handful of billing softwares being used in Kansas that are nothing except patient name, their insurance information, and then what they should be billed for. So you also have hybrid systems, and you have EHRs that encompass all of these. And Patagonia is one example where they have the practice management piece built in, they have the EHR to support that, and then on the back side, they have the billing piece that incorporates into that. A lot of the EHRs we looked at maybe only covered the health record itself, or they might have the calendar and the practice management piece but not the billing software. They might have the billing software but not the practice management piece. So just be aware as anyone is out looking at systems and trying to balance what all is out there. These are three terms that we found helpful. Our pilot also looked at outsourced billing, which would be hiring a company to kind of tackle all of the billing pieces for you. And of course, there are systems out there that are EHRs. Really, they're actually outsourced billing groups that happen to let you utilize their EHR. And then there's also the clearinghouse, which was a big learning curve for us in Kansas in terms of realizing that when you switch some of these systems, there are other clearinghouses that you might be recommended to be used, or you might be forced to use, and there are different fees that are associated with those. So that was something that kind of came in on the back end that we learned. All right, so what exactly are we talking about with this pilot project? We were offering departments a chance at training and guidance from experienced EHR consultants. Project management from myself and our team here at the Center for Public Health Initiatives. We offered financial assistance because this was focused on immunizations. We had some stipulations there, but we were only willing to pay for up to 75% of a system, regardless of how much they were going to end up spending on it, up to $10,000. So that was the max amount we would reimburse. And then, of course, what we saw as the number one benefit, a peer learning work group, a chance to go through this process with your counterparts across the state. So after we had all of our applications, we got a good mix of folks from across the state. We selected 11 counties. We were originally going to do 10, but we found funding to support an 11th. And this kind of gives you a snapshot of what we were looking at with those counties in terms of population, ranging from 2,500 to 35,000. Our smallest department had 1.5 employees. Largest had 15. You can see the difference there in their annual billing revenue and also in terms of their unduplicated encounters for the year. So what did they just sign up for? They signed up for a all-day EHR review and implementation training by a group called Synovum. We'll talk about them a little bit more later. We did demos, and I forgot to update this again. We actually did demos with about 15 vendors, and we discussed with quite a few more. We did presentations from other health departments in the state who had implemented systems, and of course, in terms of that peer learning, we did weekly calls to talk about different issues, which we ended up eventually going to monthly and then quarterly calls. We did monthly reports where everyone had to share where they were in terms of progress in the processes, and then on my side we did a lot of surveys, and we're still in the middle of doing more surveys as we really wanted to figure out what the impact these EHR systems would have on the departments both before, during, and after implementation. So this is the timeline we were looking at, starting on March 26th. This was the all-day training with Synovum. After that, everyone kind of had an idea of what they were in for. We went through quite a while of doing demos and making sure everyone participated on those as a group, which was a little uncommon, and some of the EHR vendors were a little perplexed by that, presenting to 11 departments at once. But this really gave all the departments a chance to ask questions that maybe other ones hadn't thought of, and really push those demos, I think, to be a lot more beneficial than they would have before. We went through the approach planning and the selecting of the EHR, which was a couple months period. Some of the people who started the pilot automatically knew what system they wanted. We asked them to keep an open mind, take a look at some of the other ones, and make sure that they were really sold on the system that they wanted. Phase 4 is the most critical in terms of implementation, doing the training of the software, actually getting things implemented and set up in the system, and we had everyone go live on the first week of October is really what I should say. We had 9 of the 11 go live that first week, and then the remaining 2 were live by the end of that October. So they have, at this point, all had their EHRs in place and operational for 1 full year. So after we got them implemented, we didn't just walk away and say the day's done. We went into phase 5 and 6, which is achieving optimal use, continually making sure that the system does what you want, how you want, and of course all of these systems, even a year later, we're still working through bugs and getting things tweaked and set up so that the departments are even more happy with them. When I mentioned the all-day training with Synovum, this is what Synovum brought to the table. This is something that they do for hospitals, and we asked them to kind of simplify some things for health departments and kind of bring this down to a level. And some of this stuff you really wouldn't think of, the first being a team charter, especially when we're talking about a department with 4 people. What everyone kind of knows, they've been talking about this, they talk about it every day, so why do we need a team charter? But really mapping out what you want, what you expect, and really what you expect from each other in this process is really a very vital piece in kicking off an activity like this. Department workflows, I got a star beside that one because it was something that I wish we would have done more of. It's really important to know and understand how your workflows operate in your current system and how that translates into an EHR. A lot of the EHRs would kind of have a different workflow, so health departments didn't realize they were going to have to adapt their processes to really align with the EHRs. The vendor evaluation tool is something we get a lot of questions about. The format that we were given did not really apply. I mean, it was talking about x-rays and all these different things that you need to judge your EHR on. So we are hoping to clean that up eventually and make that more health department specific. But really the idea that you have a common set of measures for how you're going to rank all of these EHRs you're looking at is really important. IT evaluations, both on the hardware side and the staff side. You see that in numbers 5 and 10, going through how you plan to set up your templates in the EHRs. That was a really interesting one for our group, because it's one thing for a department to say, you know, here's my form for immunizations. It's another for 11 to all throw different forms into the bucket and say, well, you know, we need to figure out which way we want to go with that. Some systems were unique in that you could create the system exactly how you want, and then there are several systems like Patagonia that streamline everything for you and have everyone on the state working in roughly the same template. And of course, with all this information, you get to a point where it kind of becomes too much, especially with the time frames we were looking at. So it was really important to have an opportunity to, I won't say vent about these things, but to have those conversations and let you know that there are other people kind of going through the same process, giving people a platform on which to ask questions of each other to try to figure it out was certainly beneficial. And of course, after we reviewed so many EHRs, this is pretty much what everyone looked like. Even me, myself, looking at these systems, I couldn't tell one from another other than I remember that there was a red one and a purple one, and that evaluation tool, even though we did not use it like we probably had hoped we would, it was definitely important to start raising some questions in terms of the types of EHRs that our health departments wanted. And in looking at those differences, there really is a difference between public health and private practice. And there are a lot of private practice EHRs that either claim they will work for public health departments or that are working on developing a public health aspect. And for the most part, 9 of our 11 departments were adamant that they wanted to go with a public health specific EHR. As far as the interface, this was a crucial piece, having multiple people on your team looking at these systems. There were clinical people that would look at a system and say absolutely not, but the financial or administrative side would look at the reports and the billing piece and absolutely fall in love with it. So it's important that you have a really diverse team looking at all aspects, because everyone has to spend the same amount of time in these systems. Training and customer service is really something we did make a lot of phone calls to current users of the different EHRs that we kind of narrowed down to our smaller group to get some feedback on what they thought of how the training went, what the customer service was like, were the EHRs responsive to needs, etc., and of course cost. Cost is pretty big, especially for health departments, and we got the gamut in terms of invoices, or I guess I say quotes. We had systems that were going to cost less than $10,000 to implement, and then for the exact same department would get a quote for a system that would cost over $100,000 to implement. So really get a good idea of what's out there and figure out what's going to work best for you. In the end, we had 11 health departments pick 3 separate systems. So, and of course, because we're talking on and through Patagonia today, you can probably infer that Patagonia is one of those selected systems. In terms of the implementation process and getting everything started, the setup of the data elements, the templates, getting an understanding of the workflow is of course step 1, and as I mentioned before, trying to map that out and how it's going to affect your department. Getting training on the system. One of the biggest pieces of advice we received from another department who had already implemented an EHR a year or 2 before was that the EHRs gave them training and then walked away and said, you have 4 months, test the system, practice with it, we're going to come back and then we'll be ready to go live. And what happened, because there was no pressure, there was, of course, as you probably all know, not everyone has time just to sit down for an hour or 2 and enter a bunch of fake patients in a system, so it was kind of unrealistic. And so when the EHRs would come back and say, how did testing of the system go, what feedback do you have, the department said, we haven't done anything. So we should probably push that back, and they ended up, and there were several departments that we talked to that ended up pushing back their go-live dates because just it's really hard to find the time to do the proper testing needed, and to get everyone to where they're trained up and feeling comfortable in going live. And I say that no one felt comfortable going live. That's just part of the process. So be aware and ready for that one. And then, of course, in the long term, adjusting the data elements and the workflows, and that was that piece that I think the group side of things really helped with, because everyone was able to kind of share workflows, and we had certain people say, okay, for maternal child health, I'll tackle the templates for that and then provide them to the group for feedback. So definitely some wins there in terms of the group process. And of course, with this being an immunizations grant, we had the goal of connecting all of the departments to our immunization registry here in Kansas. That's called WebIZ, eliminating the need for double data entry in one system and then turning around and putting it into the registry. It's important. We're a year later still getting all of these 3 systems up and running. We have a couple that are that have connected or in the testing phase. This happened much slower than we had wanted for all vendors. This is something where the vendors had a couple snags, the state had some snags or delays, and we really felt some benefit in pushing forward with this as a group. But you really do have to stay on top of these sorts of things, especially when you have some internal deadlines that you want to meet. We'll talk about some of those a little later. And really the biggest benefits that we can pull out from this activity, this idea of implementing the EHR as a group, and I want to make sure everyone understands we had 5 departments that independently implemented Patagonia Health. So it's not one system that everyone's kind of contributing to. It's 5 individual health departments meeting regularly to talk about how they're going about doing things. And I think that having a lead in this was certainly beneficial, which of course was my role, and I always kind of downplay that because I think these departments could have done a lot of this, but then I always have the department slap my hand and say, no, you were vital. You need to make sure people are aware that you need a facilitator, you need someone to keep things going and bring everyone together on issues. Help set some self-imposed deadlines. That was certainly important, holding each other accountable through this process. Discussing how each one intended to utilize the EHR. We had a lot of folks learn a lot just in terms of how other departments were operating and snag some of those best practices, because you really don't get to that level of detail when you talk to other departments. Sharing the burden of preparation, as I mentioned before, kind of helping each other develop those templates, and the relationships that develop from training. I mean, all of our user groups in the state for each vendor, because they went through this process together, they have a greater appreciation and really a lot of communication back and forth when there are issues or questions that we have. In the financial leverage piece also, there's some leverage there in terms of, groups being able to kind of strong arm EHR vendors to get a couple of things, but also looking at, especially with training, with Patagonia, we did a group training, and so we were able to save a little money there, bringing all 5 departments in together to one central location for 2 days to do training, instead of breaking that apart into 2-day trainings at 5 different departments. And then, of course, there's the same sort of leverage that can be done for upgrades and enhancements of the system. So I saw a little flashy thing in the corner here, so let's see if I can go answer a question, and by all means keep having some questions roll in before we roll into how did things go.
Okay, Aaron, I'm going to take the first question. We've already typed in the answer, but just for the benefit of the listeners, is your practice management system set up to bill for preventative services covered under the ACA? Also, the coding manuals available to the public? The answer is yes. We do have, we can handle the preventative services under the Affordable Care Act. All of the coding is, I'm not sure what you mean by manuals, but the coding is all built into the system.
So Monique, I think they're asking about the coding manual that was the other part of this project, and yes, they are available to the public. They are on the CDC website, and I can't remember exactly where that is. I can get that to Monique. Through this particular grant process, there's a website out there for a lot of the manuals that have been developed in a number of states. I know California has a phenomenal manual that goes into the detail of how you go about calling an insurance company to get a contract. I mean, so definitely I can research that, and Monique, if that's okay, afterwards we can get that sent out to everyone on the webinar.
That'd be excellent. Thank you. So I think the next question is you'll be able to answer probably better than I can, but I think we'll both have different answers. One of the problems with implementation of EHRs in small local public health associations, agencies is staff turnover. We here at Patagonia Health do monthly webinar training, and we can cover that with new employees, but I think that Aaron has a good answer about group.
Yes, I have lots of answers, and Monique, I know I might get in the zone and skip over it. I have a slide on staff turnover I will get to, and I think the group aspect definitely helped, and I'll talk about a few things. We experienced a lot of turnover in this pilot, and a couple of ways that we dealt with that I think would be beneficial for folks to realize. But yes, staff turnover, even outside of this, is something we almost discuss on almost a monthly basis with departments. So good question, and we will get to some more info on that. Was that the last one?
That's all I see right now.
Okay. All right, so let's jump in. How did things go? So the good, departments are stating that they are absolutely seeing some financial benefits from the EHR. Staff satisfaction kind of goes back and forth. As you can imagine, nobody likes change. Adopting new technology is rough. There's naturally going to be bugs and hiccups. I'll get to some surveys later. We did staff satisfaction surveys 3 months in, and then we are about ready to launch them again for October, and we'll be measuring a year later. So what we expect to see is a level of frustration up front with the implementation process, and hopefully a lot of that has evened out. Connections to informatics systems, it's been slow, but it's getting there. As I mentioned, we're getting connected to WebIZ, getting some of that double data entry taken care of. Productivity has increased. We've had departments, even though no one likes to hear this, talk about the amount of work, especially with some of the systems, and Patagonia is one of them, where there's a lot of burden taken off of billers. So that really allowed one department to go from having 2.5 billers down to 1.5, and that was not by choice, it was by circumstance. And once they realized that Patagonia had really improved their processes enough that they didn't need to fill that position, that was something that they've shared with the group. And then of course the value of data sharing is being experienced, not kind of what I just said, but kind of on a level of how are you guys doing these processes, what are you seeing in terms of revenues on different things. So it's really opened up a lot of communication. The bad, we have had double data entry occur for almost a year for a good number of departments. A lot of that has to do with the immunization registry having to put it in one system like Patagonia or some of the other EHRs, and then turning around and also entering it into the registry. So be prepared that you will have to deal with some of that through this transition period. There's also the idea that, 15 years ago we really had our practice management system in health departments, and that was it. And slowly we've had more and more EHRs sign on, and I think at the time of the pilot we had 2 EHRs in the state, and now I think we're actually up to 6. So we kind of multiplied the number of players, but I don't think that's necessarily bad, because we are really getting these departments on the right track to the future of public health, which is being up to date and current on what's going on, the efficiencies from EHRs, and being able to connect to the bigger picture, both on the technical side and also on the conceptual side, to immunization registries, health information exchanges, etc. So really pushing our group in Kansas forward. We did have two specific counties pick a EHR vendor. They kind of dropped off from the group a bit. They were not able to really leverage their numbers strength with the EHR. They've probably seen the least amount of wins with this, which really, in my mind, goes back to the power and the benefit of doing this as a group. So I guess my advice on that would be a group of two might not be enough to see these benefits. The unfortunate, this is the staff turnover piece. In the 18-month period that, from when we got everyone signed on, we've had 3 new directors in these 11 departments and 5 staff changes, and those are all from different departments. So the leads that were really the power horses behind getting a lot of this stuff up and going and forcing the department to change and progress ended up leaving, and or we actually had one pass away, one of the directors. So really some difficult situations in getting all this rolling, but our teamwork was phenomenal. We had one department, when they lost their biller, it took them a couple months to hire someone. They came in, nobody knew how to use the system. I mean, the system had been live for 3 or 4 months and literally no one knew what to do with it. So this department was able to send several staff members over to one of the other departments, get fully up and trained, realize that it really wasn't that they didn't know what they were doing, they were unsure of what they were doing. And this other department was able to bring them up to speed and train them, and Patagonia was also beneficial in that transition as well, spending a lot of time making sure that people were successful with this. So that turnover piece is definitely difficult. I don't think there's a good solution for it at all. We were not prepared for it. We probably should have been, and this is going to be a major part of our write-up for the CDC in terms of advice on these sorts of things is be prepared for this. Even if you have a staff of 3 people and you're sure no one's going anywhere, you're going to hit a roadblock at some point. So this might be another good place to kind of quickly stop. If there are any other questions, I'm not seeing any.
Yeah, I'm not seeing any, Aaron. We can continue.
All
If
right.
anybody does have questions, just go ahead and type them in and we'll address them as they come.
So I'm going to fly through the survey results piece and you'll see why. We are collecting financial data by quarter for 2014, 15, and 16 for all of these departments. So of course we're not going to have that 16 data probably until February of next year. I mentioned the staff satisfaction surveys. We're looking at monitoring internal changes of some of their processes. One example of that is when moving to the majority of EHRs we looked at, you went from a nurse not knowing what a ICD code was to now having to put it in every time. So definitely a learning curve for a lot of clinical staff. And then of course we wanted to know about the grant process, not just me, myself, but how this process as a group and putting all these timelines and restrictions on things, how did that impact their opinions of how things went. So starting with the financial side, these are just some of the big picture things that we were looking at in encounters, billing revenue. What you see here is a slight uptick in 2015 for total billing revenue, for example. For frame of reference, our pilots implemented the system that last quarter of 2015. And we know that there is some hardships when you start implementing a system before you can get all the billing set up. So really what we're looking at here is, if I remember the math right, it's like a 2% increase in revenue, while at the same time we saw a 14% increase in encounters. So be prepared for those first couple quarters to have a rough go and before you get everything ironed out, and we really expect to see an uptick in the first quarters of 2016 to kind of make up for some of that. On the opinion side of things, again, we did this at 3 months in. We got about 37 responses from 10 of the 11 departments. This is kind of a breakdown of who responded, and we're looking at these responses absolutely as a whole group. And even though we're not going to probably release any information about which EHR might be more preferred than another, we are going to kind of break these numbers up by vendor to see if there is a large impact based on what EHR was selected. So I'll just breeze over these. If you want to read some of the questions, this just gives you an idea of some of the things we were asking folks. First, if being part of this pilot helped with reviewing the options, evaluating the needs and systems that were required. All across the board, everyone agreed that the pilot was beneficial in implementing a system, and the majority did state that they probably would have not been able or not been comfortable moving forward without something like this. We also asked about the impact of the EHR on their specific jobs and the functions, whether it be using the calendar, just completing generic tasks, and really at this point, and again this is 3 months in, people were a little uneasy. There were definitely frustrations for different aspects, and some people were seeing wins here and losses there, and there was a lot of delay in getting everything set up. And again, this is all over the board for every EHR we worked with, so at this point we're really hoping that we see some of those numbers increase. And kind of the same thing, but maybe a little more on the positive side in terms of the EHR making their jobs a little easier on scheduling patients, documenting clinical information, billing, those sorts of things. As far as the clinical side, this is probably the piece that was the biggest hurdle. And we expected some of this, but it was definitely a lot tougher than we thought in terms of the amount of documentation that's required for clinical information is going to increase dramatically, and you might have to enter things once or twice to make sure they're in the right fields. So our clinical staff definitely had a rough go before they started getting used to the systems. So we'll definitely be keeping an eye on that in the long run. And for time's sake, I'm going to go ahead and move on, looking at what we have developed in terms of the top 10 tips we have for anyone considering implementing an EHR. And I want to pause. I see another question came in. Do you have the templates for team charter workflow? We have what was provided to us in terms of those tools that I showed. At this point, I do not, and it's not just me, our whole pilot does not feel comfortable that any of those are worthwhile for other departments. We are working on getting a project set to where we can take some of everything that I'm talking about today and rework all of those specific to health departments. Again, this was an outside agency that was brought in to do that, and a lot of them are specific to hospitals, and we want to rework all of them for health departments. Our goal is to have that done in Q1 of 2017, and once that happens, all of that will be part of our final report for the CDC report, and we will be kind of showcasing that on the road in Kansas to more departments. All right, top 10 tips for implementing EHRs, and I have this listed as small local health departments, but we actually presented this at the Public Health Informatics Conference in Atlanta just a month or two ago, and everyone there was very adamant that everything we're saying has nothing to do with department size, that this applies just as much to large departments. We often just think about a larger department being able to hire someone to kind of oversee everything and take care of all these aspects, but that, of course, is not always the case. So, tip number 1, don't implement a system if you don't need one. Know and understand what's going on in your department, and don't just implement it because you see other people doing it. Really take a look at yourself. When we were launching this brand, I had plenty of people say they wanted to apply, but absolutely loved their current system. Everyone was happy with it. They were really feeling pressured to get an EHR, and really at this point, at that point in time, there was no real reason for them to do it other than they didn't want to miss the bus. So you really need to have some pain points and look at some things that you're specifically wanting to address. We also had some departments that said, hey, I got to implement an EHR, I'm going to lose my funding reserves. Realize that you were going to send your staff in a tailspin for a year implementing a new system. There's going to be lots of headache and heartache, and of course there's light at the end of the tunnel, but doing something like that and taking on a project just because you have the money might not be the best motivation. culture is definitely big when it comes to implementing systems and going through change like this. I always use the story of Hercules and the Hydra. If you don't know, when Hercules was faced with the Hydra, he did what he always did. He went and cut the head off, tried to kill the beast. And of course we know that 2 heads popped out. So what did he do? He went back and he cut more heads off, and then more heads popped out until he had a much bigger monster than he knew how to deal with because he wasn't attacking it appropriately. Currently, we have a lot of departments that are upset with their current processes, their current systems, even some of their EHRs. What you have to realize is that there isn't a magic system that's going to fix everything, and that a lot of your problems are probably culturally or they rest in your processes. So if you have issues with your current system, unless you address the real root cause, you're probably going to have those same issues with a new system. If no one knows how to use your current project management system moving to an EHR, you're probably going to have the same issue where no one's going to know how to use it because you haven't addressed that aspect. Which leads me into being realistic. My favorite example with this is everybody wants to lose 5 or 10 pounds, and it's so easy. I don't know why people just don't do it. All you have to do is take a pill. Dr. Oz talks about this all the time, but we know that's a joke. So you have to put a little bit more effort into that, like wearing a belt. Wear a belt, now you're going to lose that weight, you're going to look fabulous. Of course, we know that too won't actually work, so we turn on to more difficult solutions such as 6 seconds a day, utilizing this workout system. But we know that won't work either. We got to have a better tools, and it's going to take more than 6 seconds a day, so we want to get one of these things, and this is going to be the answer. We keep chasing these dreams thinking that there's going to be a magic bullet that's going to be super easy and fix everything, and I compare implementing an EHR more to P90X. And if you're not familiar with P90X, this is a workout system that guarantees you will lose weight, and they do that because they require you to eat a healthy diet and work out 60 to 90 minutes a day for 90 days. I don't care who you are, if anyone does that, you are going to lose weight. It has nothing to do with a magic fix. It's just a schedule and a commitment that you stick to. That is what it's like implementing an EHR. Tip 4, the group approach. I've kind of talked about this quite a bit already, so I'll be quick, but we saw so many wins doing this as a group. We talked to so many departments that didn't do this as a group, and now they're part of that bigger user group, and they're getting all on the same page. So I would strongly recommend that people consider trying to get some partners in moving through this system and having regular communication, scheduled communication. Even if you don't have anything to talk about, a lot of people said that, and we get on the call, and we would have an hour of great conversation of tackling roadblocks and outlining issues with the systems. The team approach, this isn't multiple departments, I'm talking about internally, especially when it comes to turnover. Having a tech-savvy person, the departments that had somebody were light years ahead of the others. Having leadership and really convincing everyone. I mean, everybody complains through this process. It's just part of it. It's change. It's more work up front, especially to get stuff figured out. Know who your people are, who are your strong suits in these types of roles, and make sure that you have a backup tech person or somebody who's following along with what that tech person's doing, etc., and really trying to move along everyone together. Trying to push through and just force everyone to do it doesn't always work. Because of our time crunch, this is probably my #1 regret with our pilot project, is that we were not able to effectively measure what the impact was of some aspects of implementing an EHR. We know that there's increased productivity. We have anecdotal stories from the departments. We know that data entry has been reduced, but we never measured it. We tried to do some of these things, but health department workers are so overworked already. They don't have time to do these things and to sit back and calculate and time and measure everything that they're doing, especially across the board. I think you'd have to almost bring somebody in from the outside to do some of that, and we just didn't have the time or funds available to do that. But if you want to have a win, if you want to tell a story to your county commissioners or whoever about the great work you've done in implementing an EHR, focus on this. know where you are, know how many denials you have, know how much time it takes to implement or put those immunization records in your registry, and then how much time you're saving afterwards. This is a very critical piece that I wish we had more stories on with hard numbers. And that goes back to, we all knew it was good, but much like eating your vegetables, that's not enough of a reason. We didn't have the time, the funds, and the other things were a little more pertinent. Number 7, learning all the features and benefits. Don't just go for the shiny EHR. There are a lot of slick looking ones out there that don't meet all of your needs, and we definitely learned that with a few of the EHRs we looked at. So really, as a team, identify what's important, what you need, and how important these things are. An EHR might have a horrible scheduling feature, but does everything else for you. Does that make it a good option, or does that make it a bad option? Really weighing those types of things internally is important, and you have to start with understanding all the different aspects that an EHR offers you. Recognizing traps and pitfalls. We had so many different issues with, I'll just be blunt, with all the salesmen of some of these EHR systems, and Tom with Patagonia is one of the great ones we worked with, who really, not just Tom, but there are a handful of EHRs that understand and get the fact that they can sign you up, but if you're not successful, it hurts them in the long run. So a lot of these folks want to see you succeed, but definitely be willing to stick up for yourself, and going in this as a group and having conversations about contracts was really beneficial, because you really are on an island a lot of times when it comes to that. Selecting the system is important. We had that matrix that I talked about, that evaluation tool. I really hope that's my #1 goal, to try to fix that and make that public health focused. Doing demos with multiple systems, and the one thing I continually preach, especially in Kansas, is don't purchase a system until you can go see it live. You know, there were so many aspects when people would implement a system and say, all right, well, I'm ready to implement this. Well, the system doesn't do that. So where did we miss the boat on that? Going to a department and seeing it live in action, walking through it for a few minutes, a few hours, whatever it is really beneficial to knowing and understanding what you're purchasing. And number 10, plan. The group did such a great job of this, and we know it was vital to our success, was really assessing where they were, what they needed in order to do this work, approaching who was going to do what, how we were going to select EHRs, how we were going to measure them. Of course, everyone had different opinions, which is why we have 3 different systems, but conducting a lot of that stuff together was important. Some of the trainings that we've done are online, so doing that as a group, again, is beneficial, and even now we are still continuing to have monthly and calls with the EHR group, the user groups, and every time learning more, pushing the whole group forward. So I know I'm getting close to running out of time, so real quick I'll just touch on, here was the list of tools that we mentioned that we're wanting to revamp, and again, this will probably be 6 months away. An easy one to wrap your head around is number 8, the vendor demo script. Again, we're wanting to revamp this one as well to be health department specific, but it's really important to not let the EHR vendors and the salespeople hook you into looking at one specific aspect of the system. Write out a script of John Doe comes in, here's his name, here's his date of birth, schedule this appointment, these are his vitals, and this is the type of procedures that he had done. See it active in the system, consistent from one vendor to another. It really makes you appreciate and understand where the gaps are in a lot of these different systems, and helps you ask the right questions because you're looking at the exact same thing across all systems. So a lot of vendors just kind of want to walk through and give their little spiel, and it's important that you understand and see the same thing in every system in order to help measure and evaluate that. So I know leaving only a little bit of time for questions, so I apologize for that. But that is all I have. So Monique, I'm going to turn it back over to you.
All right, we're going to go ahead and just leave your slide up, I guess, or right here. No, this is good, this is good. And we did have one more question come in. Will the slides from this presentation be emailed to all of us? And yes, I can, I'll be sending everybody an email with the recording and the slides. as soon as the recording is uploaded into my system. That's either this afternoon or Monday. If there's any other questions, you can go ahead and put them in now.
And real quick, I'll add, I don't know if I said it, but we are developing a large report for the CDC on all the work we've done, the impact of this, and including the toolkit that we're looking at developing, and all of that will be given and turned over to the CDC, which I know they're wanting to share through the NACCHO platforms and some of the other things, just to make sure that that gets shared with the broader audience. So keep an eye out for that.
Good mention. Okay, well, if there's no more questions, I mean, I'll leave it open for a little bit if anybody's typing lengthy questions. I know it takes a minute. At this point, I'll just thank everybody for joining our seminar today and attending. We have a great appreciation for the work that Aaron is doing in Kansas, and I know that it could be beneficial to other states as well, which is why we asked him to come today. So thank you, Aaron, for presenting today. Thank you all for coming, and like I said, I'll be sending out an email as a follow-up to attach the recording and some additional content. Once I get the coding manual from Aaron, I will include that as well. Okay, I don't see any further questions. Also wanted to mention next month on November 8th and November 11th, we will be conducting our next webinar called Best Practices of Data Migration Process. That'll be presented by Don Sargent, who is our Customer Experience Director here at Patagonia Health. And you should be seeing emails regarding that for registration links and such. You probably already have. Okay, well, if anybody has any further questions, once we disconnect the webinar, you're welcome to email them to me and we'll get them answered for you. You can submit them through the webinar link that you had, or you can send them to info@patagoniahealth.com. And once again, thank you very much for attending. Oh, wait, another question. The National Learning Consortium has a vendor evaluation matrix tool. Okay, not a question, a comment. Thank you, Chris, for posting that. Okay, thank you very much, all.
Thanks.